discussion is TEF. TEF is nothing but tracheo-esophageal fistula. So what is TEF is abnormal congenital or acquired communication which is occurring between the trachea and the esophagus, and this can lead to pathological air fluid exchange between the two structures. So if for example this is the trachea, and this is the esophagus, so there is some abnormal communication which can be congenital or acquired, and this is causing the gas and the air, the whatever the fluid exchange is occurring between these two structures. So the definition is abnormal congenital acquired communication between trachea and esophagus which leads to pathological air fluid exchange between these structures. So important association is there is a gene called as NMYC gene mutation. So what are the things which we can see during before or after birth? So before birth, it is usually associated with polyhydramnios, that is there is increase in liquor quantity or amniotic fluid is increased. So also there is you can detect this associated congenital anomaly in prenatal scan. After birth is excessive drooling of saliva will be there because of the abnormal connection between the trachea and the esophagus. Might be because of the atretic end of the esophagus. There can be excess drooling as well as respiratory distress because of the involvement of the trachea. Okay, so coming to the types, so these are the types of TEF. TEF can be classified as A, B, C, D, E and F. So coming to type A, type A is a pure esophageal atresia without TEF. So we can see here in the picture that this is the trachea, and this is the esophagus. So both the ends are atretic, means they are blind. So coming to the type B is esophageal atresia. It is esophageal atresia but there is a proximal TEF. Type C is the most common type where there is esophageal atresia. There is esophageal atresia with distal TEF. Distal segment is going to a TEF. It is most common type, that is 85% of the cases. Coming to the type D, there is esophageal atresia with both proximal as well as distal TEF. Proximal as well as distal TEF is present. Whereas type E is also called as H type, where you have a proximal, there is a TEF, that is both proximal and distal TEF. There is no esophageal atresia, only there is a fistulous communication between the trachea and the esophagus. Coming to type F is also called as esophageal stenosis. There is no TEF but there is esophageal stenosis. Okay, coming to the management of the condition, that is TEF, it is based on a criteria which is known as Waterston's criteria. So Waterston's criteria uses two important parameters, that is birth weight and pneumonia. So birth weight in kgs and pneumonia. Okay, so and this is the action plan. So if the child weighs more than 2.5 kg and there is no pneumonia, then you can directly go to the surgical treatment. Whereas if the child is between 1.8 to 2.5 kgs, then the pneumonia may or may not be present. Then you treat pneumonia if pneumonia is present using antibiotics and try to build the weight till 2.5 kgs. Then after these two things are met, then you can go for surgery. So if there is weight is less than 1.8 kgs and with or without pneumonia, then you have to do something called as gastrostomy, where if this is the stomach, you put a tube to the stomach and start the feeding through this tube, and as the nutrition improves, the child will gain the weight, and also treat pneumonia if it is present, and followed by delayed surgery is preferred. Okay, so based on this criteria, finally the treatment for TEF definitive treatment is surgical management. Surgical management can be divided on what type of TEF it is. So if it is a type A type of TEF, that is where there is proximal and distal esophageal atresia, then based on the length of the segment, if the two ends are closer, then you have to start to anastomose them because they are closer and it's easy to anastomose. if those two ends are far apart, then there can be two type of things. That is, one is gastrostomy, as I already mentioned here, that you have to start feeding through this tube directly into the stomach, and because of the improved nutrition, the two ends will start growing together and you can anastomose it. Or you can use something called as a flourish device. Flourish device is a magnets are present kept in both the ends, two ends of the atresia, and because of the pull of these magnets, the segment comes closer and starts growing. Okay, so coming to the next is, that is type B, C, D and E type of tracheoesophageal atresia. What you do is, for example, this is B type of atresia, where you have proximal TF with distal esophageal atresia. So here you remove this connection, that is TF, and then using PDS, that is polydiaxone suture, you repair this part of the trachea, and here you anastomose the remaining segment. This you remove it here and bring it closer. Okay, so this is the management of TF. So thank you for watching.